coronary imaging and physiology with all the experts we have from national and international arena. I have the pleasure of introducing Dr. Devdata Bhattacharya as our moderator, who is a clinical director and senior consultant interventional cardiologist and chief of cath lab services at the Rabindranath Tagore International Institute of Cardiac Sciences. Besides his vast experience in interventional cardiology, he is also one of the pioneers of coronary imaging in Eastern India, particularly the IVUS. Also, I introduce as a co-moderator Dr. Shubhra Banerjee, senior consultant interventional cardiologist at Apollo Clinicals Hospital, Kolkata. Apart from his 2 decades of experience in interventional cardiology, he has an excellent record in academics as well. So, if Dr. Devdata Bhattacharya is around, I hand over the podium to Dr. Devdata Bhattacharya and Dr. Shubhra Banerjee for moderating the first session of the coronary imaging conclave. Over to you, Dr. Bhattacharya.
Dr. Devdata Bhattacharya has some issue in joining, so I don't.
Okay, so I think
introduce Silvamani sir first.
Yes. Dr. Silvamani, S. Silvamani, who does not need much introduction to the national field of cardiology. We have been actually seen his excellent meeting for the last 3 days. He's senior interventional cardiologist from MMHRC Madurai, and he will be talking on eye-optical results, the first ever prospective clinical study on imaging from India and SA. So over to you, Dr. Silvamani, for your presentation.
Thank you very much for this opportunity, and it's always a pleasure there to be with friends at Kolkata, Hasra, and Bhattacharya, so many seniors there. So it is really hold on, why share here? And it is really a pleasure, and thank you very much. And can you see my screen now?
Yes, we can actually.
Yeah, okay. And but this is one of the very interesting studies which has been done here. And basically, it is to know the importance of OCT and what is the clinical application. So it is basically OCT and angio-co-registration on what changes does it make when compared to just a coronary angiogram during our real-time practice. So that is what was done in this study. And the principal investigator was Roni Matthew. And we were all, our center also have contributed. We have contributed around 100 cases for this trial. And this aim of this optical study aims to determine the impact of real-time OCT and co-registration with angiography on physician decision-making for PCI optimization in India, especially South Asia. And there were 9 centers in India and 1 in Bangladesh. And primary objective was to assess the change in treatment strategy with OCT and ACR. Pre-PCI, they looked into the strategies, what changes occurred, especially if there was any need in the lesion preparation, or was there any lead in the change in the intended stent of length and size of the stent, and of course for the landing zone. If there were any changes in this compared to an angiogram to OCT and ACR, they recorded it. And post PCI also, they looked into what was the need for any change compared to only on angiogram, especially for malopposition, edge dissections, and stent under expansions. So, and secondary objectives were the procedural outcomes, angiographic success and procedure success, MACE at 1 year and 6 months, and of course, lab metrics like additional time which was used for OCT and ACR, and additional contrast volume which was used for OCT. So the flow was like this: you do an angiogram, and after angiogram, you fix a strategy, like what you are going to do now. And after that, you do the OCT, and then you look into the strategy now. Is there any change between from this stage to this stage was recorded? And then after this, it went into ACR. And from OCT to ACR, was it any change? This was recorded. And then PCI was done. And after PCI, OCT was done. When compared to the final angio after PCI and OCT, is there any strategy change that was recorded? And then, of course, ACR was added. And again, they looked into if there was any strategy there, change in that strategy. And all the DICOM images and OCT runs were analyzed independently at the core lab. So this is how was the flow of this study to know the impact of OCT or ACR when compared to only angio-guided PCI. So this was all real-time patients. That is 500 all-comer patients from India and Bangladesh. And the 472 were included, and follow for 6 months is over for 443 patients, and 12 months for 241, and it is still going on. And variables which were analyzed apart from routine like demographic, medical history, indication, vessel, and treatment, very important assessment was they looked into the lesion preparation, like was there any change in the use of balloon or some additional device, and then any change in the length of the stent, diameter of the stent, and of course stenting strategy and landing zones. These were analyzed. And then other variables like post PCI, they looked into like OCT and ACR and major adverse events at 1 year, and time to conduct OCT and ACR was also assessed, and contrast volume was assessed there. So inclusion criteria was any patient with a native coronary artery disease who was eligible for angioplasty was included in this. And of course, the exclusion was like in any standard trials like hypotension, shock, requirement of vasopressor, extreme angulation, extensive vascular tortuosity, renal insufficiency, and if the patient could not take dual antiplatelet for a year, and any other medical conditions where it was not fit, the standard exclusion criteria was included in the study. And when you look at the baseline, almost around 17% of the patients were previous PCI, and 5% were around post-CABG patients. And most of the indications were around 25% with unstable angina, 20% was recent STEMI, and stable angina was around 18%, and non-STEMI around 16%. So these were the characteristics of patients included. And when you look at the vessel, around 62% of the vessels were in the LAD, and 23 in the RCA. And 11 was osteal lesions, 7% contained thrombus, and almost 50% of patients had calcium, but 11% was severe calcium. So this was the basic variables in that study. And when they assessed the pre-PCI strategy changes, what happened is when they assessed, compared to angiogram with only OCT, when they assessed, there was a change in almost 76% of the time. So pre-OCT is very, very important. That is the implication of this study compared to post. We will just discuss that. So in pre-PCI, only with OCT, there was around 25% in lesion preparation. Probably they required a cutting balloon or scoring balloon or one extra bigger balloon, something like that. There was a change in that. And length changed in almost 53% of patients, diameter of stent in 36%. And of course, change in the landing zone is very, very important, especially disease where you select a normal to normal vessel. So 61% change was there. It was in pre. And when this OCT was added to angio co-registration, there was another 22% change there. So basically, there was a significant change when both were added together, pre-procedure itself. Here 76% and here 22%. That was the important finding that we could make out in this study. And of course, post-PCI, when OCT was assessed only with angiogram, there was an overall change of 30%, including tissue prolapse. Very important is under expansion, malapposition, and stent edge dissections. These were the important factors where you had 30% change in the decision making compared to only with angio post-procedure. And post-procedure, when they added angio co-registration, there was no change. But pre-procedure, it was very, very important to add ACR. And overall, put together, angio as well as ACR, angio co-registration together, there was a significant change there. almost 86% change, almost 90% change pre-procedure and 30% post-procedure. So that is the importance of the study when they analyzed it. So when OCT and ACR put together based on only angiographic findings, there was 90% change in the decision making. And they analyzed the time to conduct also. To conduct an OCT pre, it took almost around 6 minutes and post around 10 minutes. And to assess, to go through the lesions, post and pre, these were the timings. And overall, there was 40 plus 20 ml, plus or minus 20 ml contrast additional use for OCT. And of course, in this study, it was 100% angiographic and procedural success. And to conclude, this was the first South Asian study reporting outcomes of OCT and ACR guided PCI in patients with CAD. OCT and ACR changed angiographic based decision in almost 90% of the patients pre-procedure. So that indicates pre-procedure OCT is very, very important. And around 30% of the time, there was a change in post-procedure analysis also. Only ACR, when you compare, it was around 22% needed. So the 22% of the change was noted there. So the study is still follow-up is going on, and probably the further studies changes will be published later. Thank you very much for the silent listening and for the opportunity to present it here. Thank you.
Thank you, Dr. Selvamani, for your excellent presentation. May I add that we have our expert panelists, Professor Julio, Professor Jiad Ali, Dr. Selvamani, and Dr. Shubhanand Roy amongst us. Dr. Shubhanand Roy is the Director of Interventional Cardiology at Fortis Hospital, Anandapur, Kolkata, and he has more than 25 years of experience in interventional cardiology. So welcome, Dr. Shubhanand Roy, to the meeting. And we also have Dr. Selvamani and Professor Jiad Ali and Professor Julio. So on this speaker is going to be Professor Julio, and to introduce him, he's the Director of Interventional Cardiology at Papa Giovanni Institute in Bergamo, Italy. He was trained in interventional cardiology at Clinic Pasteur, Toulouse. He has a long-standing research expertise in the field of high-resolution intravascular imaging, acute myocardial infarction, and stenting. He's a pioneer in clinical use of light-based imaging for evaluating coronary atherosclerosis and stenting. He was awarded at the Mayo Clinic and St. Mary's Hospital. So he's going to talk about orange is the new gray in OCT. So over to you, Dr. Professor Julio, for your talk. Thank you.
Thank you very much. Let's try to get share my screen. Can you see my screen?
We can.
Okay, good. So thank you very much for having me at this meeting. I think it's really a pleasure to talk with the friends. Very important data came from Dr. Selvamani, and we will discuss later. I'm talking in the same line of the past. What we can see on the table in our cath lab is an incredible growing of complexity, where complexity means left main disease, means severe calcification, CTO, major bifurcation, instant restenosis, and diffuse disease. How imaging can help us in guiding this intervention? Well, first of all, why OCT compared to other technology? Here you have a pair of the same cross-section in the same patient obtained with OCT confronting with a high-resolution IVUS. You can see both are very nice in terms of image quality in cross-section. But what OCT is adding, and you can see immediately how much is the level of the difference, is the pristine lumen due to the light technology in the longitudinal view. So it means that at the end of your pullback, this lumen can be automatically measured compared to IVUS, where you have a very insert lumen profile. So the first step that we were able to provide to the doctor working with the clinical cases was online guidance in a complex case based upon what? Angioregistration, Dr. Salvamani was explaining, being linked with angio. Then what? Automatic measures. And automatic measures that in the past were essentially focused on expansion and malposition, now are more focused on pre-procedural assessment. This is to be really linked to the optimal PCI guidance. We saw this very significant high impact of a pre-PCI OCT in eye optical, but for many reasons, you can also increase the value of this pre-intervention assessment when you are moving more and more toward complex lesion. And we know that you needed to get morphology inputs. You may change the length, you might change the diameter of the vessel, of the stent size, and then there is a large impact also in a post-PCI. So the importance is to bring information. Information about what? Well, information about complexity means immediately calcium. Calcium, unfortunately, is extremely underestimated by angio. That is quite low sensitivity. Also, in the case of a severe calcification, you cannot be fully informed. When you finish this absolutely acceptable implant in a severe calcification with this type of results, this is what you have inside, measured by the OCT with automatic detection measurements. And you can see display on your screen the level of underexpansion, and you can also have some precise idea to the point that they are more underexpanded and to the reason why is underexpanded. Here you can see the impact of calcium. So calcium is dramatically important. The more you are moving in complex, the more we need to detect when, after the stent, no, before. Why? Eye optical was showing, because you need to make your plan before placing your stent. This is what we have new coming from OCT, where beside us, we have the artificial intelligence working with us to provide the data and measurements. This is what we can see. Totally new graphic display. Here is the automatic calcium identification section by section and displayed directly in your angioregistration. So when you're going in a section, you can see, measure the arc of the circumference, the thickness. If you are moving out from this segment or moving to a limited calcium, you have information about the total angle and the maximum thickness outside. And you know with the co-registration that you can prepare this segment quite easily by using the standard approach. In addition, you started to have this white line beside the automatic lumen. What is the white line? A dotted white line is EEL. So your guidance is based upon EEL and upon the lumen, depending what is displayed. But at the center, there is the calcium detection and the calcium measurements in terms of arc and in terms of thickness. So you can decide how to prepare and then place your stent, and then you have a precise information, section by section, displayed longitudinally in terms of expansion. And if you are moving, you can see at a different level, a different range of expansion compared to your landing zone and reference segment. Could be too much, it could be few. And then it's very important to try to rely to the lumen when you don't have EL, or to see your ratio with the EEL. So you are going to be provided of both type of measurements. This is very important for what? For optimizing your procedure. And then at the end, you can compare on your display multiple pullbacks. Here you have the pre-procedure that has been mentioned before, and the post-procedure, where you have represented your stent, you have divided with a dual, non-tapering in this case, and you have the expansion for each segment. And you are moving, and you can see how much the stent is fully opposed, and so on. So in addition, with OCT, you can clearly understand the impact of any single methods for lesion preparation. Here you have the baseline, you have your lumen profile, the longitudinal view, then you decide due to the circumferential calcium expansion to go with a rotational atherectomy. This is what the technique might provide you after the treatment to show the effect of the atherectomy. And then if you need something in addition, you can go with some more aggressive treatment, cutting or NC balloon or scoring or intravascular lithotripsy, and search for fracture. They are clearly shown. And you can compare in these different pullbacks what did you achieve from a baseline to the end, also in terms of measurements. In addition, you have the beauty of the 3D when you are approaching very complex lesion disease and stenting. You might be informed about the multiple aspects. Likewise, the length of the crescent segment, likewise, the opening of the vessel and the new carina arrangement. Very important to have this data for understanding the level of complexity. In addition, when we are talking about ACS patients, Dr. Salvamani was showing eye optical, mainly unstable patient. It means something to deal quite frequently. So setting where the thrombus is forming easily, here is immediately after the stent deployment. It seems large, it seems good, but you can start to see all of these micro defects along the stent, and then you decide for the treatment, and they are disappearing. When you are zooming on the cross-section, you can see clearly the beauty of this technique and the level of sensitivity in detecting thrombi inside the stent and also outside the stent on the top of a plaque not directly involved. And then after the injection of 2B3A small molecules, you can see the beauty in cleaning the thrombotic aspect. Of course, unstable patients means a different type of physiopathology. Here you have the face-to-face of plaque rupture compared to erosion, and we know that this technology can be very useful in detecting. When you are confronting with a very complex situation that seems to be just a single mechanism, likewise in this case, a diffuse in-stent restenosis, you have the possibility going in details to differentiate recanalized thrombi, malapose stent, growing of neointima, underexpanded stents, and then the fibrotic neointima response. So based upon this pre-assessment, you can arrive to have the good full expansion despite the longer segment with almost all full apposition. So there is a time where the things are changing. For many, many years, we had the patients, we tried to make interpretation of the images and then to make our decision-making and guide the procedure. Now it's going to be a little bit different. Instead, also parallel to us, we are asking to the imaging tool to make substantial support in interpretation, measurements, and display to help us in the judgment. This new data obtained with calcium identification measurements and EL had a trained system of 1,000 of images. So we think that OCT settled a new paradigm in imaging-guided PCI through what? Providing a full spectrum of automatic measures instead of subjective cross-section interpretation. And one reasonable workflow could be follow the MLD max statement. Then you have a point-by-point angio co-registration to integrate the imaging in a workable PCI flow. And we saw the role of all the different time provided by Dr. Selvamani. You have accurate assessment and display of calcium at the pre-procedure. That is normally a growing issue for stent expansion. The new software, Ultron 1.0, set a standard for precise AI-driven PCI. Then you have a full spectrum of measure-based stent optimization, including expansion, malposition, and the dissection, and of course, unique value in ACS to recognize thrombus, to differentiate rupture from erosion, and orient the personalized treatment. Thank you very much for giving me this chance to present. Back to you.
Thank you, Professor Guglio, for your excellent presentation. I request you to stay over for the session as an expert panelist. I hand over the session to Dr. Devdata Bhattacharya and Dr. Shubhra Banerjee as co-moderators for this session. Over to you, Dr. Bhattacharya.
Thank you, Dr. Dev. I think Shubhra will introduce me and then I'll start.
I would, yes. It's my pleasure to introduce Dr. Devdata Bhattacharya. He's the clinical director, senior consultant, and chief of cath lab services at the Rabindranath Tagore International Institute of Cardiac Sciences. He has more than 20 years of experience in interventional cardiology. And he's going to talk on how I use OCT to solve problems and optimize my results during PCI. With this, over to you, Dr. Bhattacharya.
Just bear with me, I'm going to share my screen here. Okay. Can you see my slides?
Yeah, it shows case 2.
Yes. Okay, I'll start at the beginning. So thank you very much, Shubhra, and thank you, Abbott, for organizing this. Thank you, Dr. Selvamani and Dr. Guglielmi for being here. And this is, I'll present a couple of cases. Can you hear me well, Shubhra?
Yes, we can.
Yeah. So you have actually listened to, sorry. I want to get out of here. Sorry, just bear with me. I'm being a little foolish. Yeah. So this is my presentation. I hope you can see them now. Yeah. So you have listened just to an excellent lecture by Dr. Guglielmi, and I think all you need to know was in that lecture in a very precise, concise form. And what I'll show you is 2 cases. And I think you will recognize some of the principles that I have used in these 2 cases to solve and optimize my results. So my first patient is a 74-year-old male who is diabetic, hypertensive, admitted with shortness of breath on exertion and chest discomfort. Cardiac troponin was not elevated, but there was a regional wall motion abnormality in the inferior wall with an EF of 50%. Now, this was his angiogram in 2012, and you can see that there was this complex LAD-D1 bifurcation. And this was his RCA at that time. And I told him that we should fix the LAD, but he insisted on medical management. And that was what he was on for 9 years before he came back. And he said, now I think you should fix me up because I'm having chest pain. So that is the story. And this is the angiogram in 2021. So these are some stills. You can see that the RCA is now a CTO. There is this LAD-D1 lesion, which has progressed since 2012. And there is this tight circumflex stenosis as well. So this is a diabetic with triple vessel disease with chronic total occlusion of the RCA. And he is a sort of family friend to me, and I told him that you need a bypass operation. But he absolutely insisted that he was not going to have it. And this was at the beginning of our second wave. And he's some sort of an astrologer, and he told me that the next 1 month is going to be hell, and I'm not going to stay in hospital during that time. So you fix me and let me go home in 2 days. I got a surgeon to see him who tried to convince him, but he was not convinced. And I said, okay, I will try to fix the RCA first, because this, I think, is the symptom-producing artery. And then we'll see how it goes. If we fail, you have to go for bypass. If you don't want bypass now, you can come back later. So we tried to fix the RCA first, and we were successful in wiring it. So this is a retrograde injection-guided wiring of the RCA. And after serial predilatations, we got some flow in the RCA. And you can see that the PDA and the PLB is also quite severely diseased. And this left me with a dilemma, because I did not want to do too much stenting here, because usually the result of stenting along this entire region will not be good. So what I decided was I would dilate the PLB, and then I would land my stent just at the crux and do nothing to the to this very diseased PDA. Because if I did this, then I would compromise the PLB. So that is what I did. And after some post-dilatation, this was the final result in the RCA. Now, at this point, I told him that we have done the RCA, but it is not absolutely perfect. And would you like to stop here? Would you like me to stop here? Because it will take care of your symptoms for the while, and then you can come back after the pandemic and get yourself operated on. He said, no way. So I next decided to do the circumflex. And you can see that the circumflex is also quite tightly diseased. And I thought that if I could get away with a cutting balloon of the circumflex and not stent it, I will try to do that. So I did a little pre-dilatation with an NC balloon, and then I took a 3.5 by 6 Wolverine cupping balloon. And then I did the OCT run. And you can see from the angiogram that probably you could be forgiven for thinking that there is no significant dissection here, but this is what we saw on the OCT. So these are the top two cuts, and then you can see that there is this dissection here, which cannot be ignored, and it's a large vessel. So we decided to stent it, and you can see that the proximal and distal landing zones are quite satisfactory. I was a bit lucky. This is the only bit of luck I had in this case, that this landing zone was clear of this LAD-D1, which I had to do. So I stented the circumflex, and then we did an OCT run, and you can see that there is a little bit of under malapposition in the proximal part of the vessel. So the rest of the vessel, as you can see, is quite okay. So I'll skip the slides. And here we did some further optimization. And then Once we had done it, we thought, let's stop here. We will fix the LAD later on because the LAD was diseased from a very long time. But again, he insisted that no, fix it today. So we said, okay, we will pass a wire and do an RFR. And this was the RFR. So now we were committed to doing the LAD as well. And this is again a bifurcation stenting. So I was not going to put 2 stents in this LAD D1. So what I decided was I will see if I can get away with 1 stent. So I did a gentle dilatation to the first diagonal artery. And then I pre-dilated the LAD with a 3/12, and I really gave it a good dilatation. And then I just positioned the stent just up to the LAD ostium and across that diagonal. And fortunately, after post-dilatation, the LAD result looked satisfactory. I'll show you a bit later. What happened after that was we wanted to do a kissing dilatation of both the stents. And I passed a wire, and then after I had passed the wire, the balloon wouldn't go into the circumflex artery. So I did a OCT at this point of the LAD, and this is what it showed, that you can see that the wire in the circumflex has gone in through a very crowded area of the circumflex, which is why it was not going. So I rewired it based on this, and then we did some simultaneous dilatations. And finally, we did OCT through the circumflex artery to finish our case. And this is the final run. So we were satisfied with this result, given the conditions. And I told him that we will get your diabetes and your cholesterol under control, but remember that there could be a recurrence, and be prepared for more procedures down the line. So the conclusions are, for this case, is it's coronary atherosclerosis, as you can see from here, is a slow progressive disease, and intervention is effective during phases, most effective during phases of instability. Such patients as the one under question should always be offered CABG as the first choice, which we did. Proper consenting and discussion is important, as CABG is proven to be better in the long term by clinical trials. And the patient should have an opportunity with a face-to-face meeting with a surgeon, which did happen in this case. And the culprit artery causing the ACS, which in this case was the RCA-CTO, should be addressed first. The patient was made aware that if this failed, he would go for CABG. The circumflex was attempted next. And then the LAD. And what we did was we did OCT to optimize the results of the circumflex stent. We did OCT to find out whether there was a significant dissection, and which there was. We carried an FFR to the LAD to assess the physiologic significance of this long-standing lesion. And we had to do stenting to the LAD as well. And after we had done stenting to the LAD, when we tried to pass a wire in the circumflex, it wouldn't go, and an OCT guided. When we did the OCT of the LAD, we saw what had happened, and we rewired the circumflex, and we did kissing balloon dilatation and OCT pullback from the circumflex artery. Triple vessel disease in diabetics are prone to recurrence, and every attempt should be made to optimize the results of PTC in such patients. And I think in this case, both OCT and RFR helped in this decision-making and optimum expansion and the position of the stented vessels. So Shubhro, if I am over my time, I will stop here. But if I have 3 minutes, I will show another case. It's up to you.
Go ahead. We can afford 3 minutes, I believe.
3 minutes then, thank you. So this is another patient, and Dr. Guliami was showing you about calcium, and it is, as we all know, this is the one of the most difficult problems in angioplasty. So this is a 74-year-old male diabetic hypertensive. Again, he had anemia due to gastric antral variceal ectasia. He had again PTCA 10 years ago and presented with unstable angina, severe calcific double vessel disease, and an EF of 50%, and that also during this first wave of the pandemic. And we plan to do an OCT-guided intravascular lithotripsy and PTC and stenting to LAD. and RCA. So this is our left anterior descending artery, and you can see that it is very severely calcified. And you can see that there is a proximal stent with calcium around its edges, and then there is a lesion which is distal to the stent, which I have circled, and this is also a calcific lesion. So we did an OCT, and here you can see the calcium distribution, pretty much concentric distally, but there is a good lumen there. But as we come up, the lumen gets narrower, the calcium gets thicker, more concentric, and you can see it is very, very thick calcium there. And as we come to this segment, you can see that it is really something that needs to be addressed before we can even think of stenting. And this is the previous stent, and you can see that the previous stent is reasonably well deployed, and there is not much of neoatherosclerosis that has happened in the past 10 years. So armed with this knowledge, so these are pictures of the OCT at the very tight bit, and with this knowledge, we took the IVL balloon. This is a 3x12 balloon and 2 cycles of 10 pulses each. We could see that the balloon had expanded in the mid segment. We did an IVL OCT again, and you can see the cracks in the calcium that has happened with the IVL. And then we took a 3x12, took it up to 22 atmospheres, and this is a 3x23 Alliance expedition, which you can see is getting deployed reasonably well. And then we post-dilated it, and this is the final OCT run. And you can see as we go through it, the first stent will come first. You can see there is not much disease at the edge of the first stent, which looked bad on angiography itself, but this is quite reasonable. We don't need to touch this stent, and then we will come into our second stent. You can see that there is a gap between the two stents, and this was deliberate. We did not want to go into that first stent, and you can see here that our stent is quite well expanded given the very, very bad calcium that was there. The calcium has cracked, and it has resulted in a good lumen gain, even in the very tightest part of the LAD. Next, we went to the RCA, and you can see from this angiogram, again, there is drum track calcification in the RCA, but there is one spot where there is a stenosis there, and this is our OCT through the RCA, and I don't know why it's not playing. Okay, let's try to play this. Yeah, so as you go up, you will see this very tight stenosis in the RCA, and I will try to show you where the entire RCA is calcified, but you can see there is a reasonable amount of lumen distally where you don't want to go, and you want to address the very tight segment with IVL. So we are coming up to that segment now, and here
yeah. Have we lost Dr. we may have lost Dr. Devdata.
It's another.
Okay, he's sharing his screen, I think, once again.
To address the very tight segment with IVL. So we are coming up to that segment now, and here.
So Dr. Jiadali is running out of time. Could you please request?
Yes, sir. Yes, sir.
Dr. Banerjee, if you please introduce Dr. Ali and start, because.
Okay. All right. Thank you, Dr. Devdata. It was an excellent demonstration of cases, and we'll take all the questions later at the end of the session. Now it's my privilege to introduce one of the stalwarts in interventional cardiology, Professor Ziad Ali. Dr. Ali is a board-certified cardiologist specializing in interventional and structural cardiologist at St. Francis Hospital and Heart Center in Roslyn, New York. He is an internationally renowned expert in complex high-risk PCI, including treatment of CTOs. With this and without wasting time, over to Professor Ziad Ali, who will be talking on zero contrast PCI.
Thank you. Are you able to hear me okay?
Yes, we can.
Great. I'm sorry. Today is Father's Day. Julio, you'll know. Father's Day is a very, very special day.
Yeah.
To-
Got it.
Father's Day is a very, very special day for us. So we need to, I need to be with the family. So I'm sorry, I'm in a little bit of a rush. So today we're going to be talking about treating CAD patients with renal disease. These are my disclosures. So what we're going to do here is review some of the challenges and clinical data of coronary artery disease management in patients with CKD that need PCI, and discuss an algorithm-based approach to minimizing contrast exposure during PCI. Then we'll do perhaps some case of low or no contrast PCI. So why is this important? It's important because CKD4/5 or end-stage renal disease patients account for almost half of all deaths with a known cause in patients with CKD. It remains the leading cause of death after renal transplantation, and exclusion from randomized trials has really led to a paucity of data, making cardiovascular management in this population very challenging. So why is this important? It's importantly because, as you can see, patients with chronic kidney disease who develop contrast-induced nephropathy have a very high event rate. And even those patients who don't have CKD who develop contrast nephropathy have a high event rate. Only those patients who are CKD-free with no CIN are the ones that are normally included in the trials. As a result, revascularization by PCI in patients with advanced CKD is drastically underutilized. This will bring up this concept of renalism. Renalism is the concept whereby patients who have CKD and have a clinical indication for angiography and revascularization don't undergo that treatment due to a fear by the interventionalist that they may put the patient onto dialysis. And of course, in medical school, we're all trained to first do no harm. And as a result, we want to minimize the likelihood of harm. And as a result, we may actually defer disease-altering procedures in patients. And renalism is not just something from the 2000s. Renalism is real. In the ischemia trial on which I was an author, you'll notice in the regular ischemia trial, the non-CKD arm, the revascularization to catheterization rate is 83%. But if you look in the CKD patient population, the revascularization to catheterization rate is 58%. And this is a manifestation of renalism. You can see that in the ischemia CKD patient, only 50% of the patients who are randomized to the invasive arm actually even got intervention. Most of the patients actually ended up not getting anything. Why? Well, if we look at the data, what you'll notice is that the risk of dialysis in patients in the invasive arm is threefold higher than the conservative group. So in fact, there is a threefold hazard for patients who undergo invasive management of CAD of the risk of dialysis in the short term. And that's why this translation occurs. And that's why we are afraid of treating these patients. But this is the problem on the other hand. You'll see that atherosclerotic progression in CKD patients is very aggressive. In non-CKD patients, the risk of rapid progression of lesions is relatively low, as we showed from the PROSPECT study. But in patients with advanced CKD, this is very problematic. And you'll notice in less than the span of 1 year, you'll see very rapid onset progression of kidney disease. You'll also notice that the benefits of PCI in patients with non-ST elevation in CKD is prevalent. In patients with GFRs of 60 to 90, 45 to 60, and 30 to 45, there is a significant value for revascularization compared to control. However, you'll see in the less than 30 group, there's no significant benefit. And that's probably related to these wide confidence intervals and the fact that no one is really investigating these patients in a meaningful way. What are some of the potential management strategies? Well, we've tried experimental devices like Divert and RenalGuard, but experimental medical procedures such as Divert, RenalGuard, N-acetylcysteine, sodium bicarbonate, and isoosmolar contrast have all failed. Only 2 clinically validated strategies exist. The first is adequate hydration, and please recall that these patients with adequate hydration the GFR is only 40. In the intravascular imaging guidance arm, you'll notice that patients who undergo IVUS-guided PCI have a significant reduction in contrast by about 5-fold. In patients who have ultra-low contrast angiography, we can minimize this risk. Ultra-low contrast angiography is divided as a contrast volume to eGFR ratio of less than 1. The eGFR, if it's less than 15, the contrast can be diluted. And when you perform an ultra-low contrast angiogram, you really should be only performing 3 views. In the right coronary, an eleocranial, in the left coronary, an epicranial, epicaudal, and the left ventricular end diastolic pressure should be used to guide hydration. Here's an example of an ultra-low contrast angiogram. You only need an eleocranial in the right coronary to be able to determine whether or not there is an ambiguous lesion or tight stenosis. In the left cranial epicranial, you're able to see the LED in the diagonals, and in the epicaudal, you can assess the left main of the circumflex. Now, in the situation where you end up comparing this to a standard of care angiogram, the amount of contrast is approximately 7-fold higher. Now, one of the reasons we take so many angiograms is because we want to make sure that we're not missing a lesion, or we remove ambiguity otherwise from ambiguous lesions. However, we have many tools now to be able to do this. We have IFR, FFR, and here you see a patient with a GFR of 8 with an ambiguous lesion in the proximal circumflex, and we can do an FFR with pullback or RFR with pullback and determine that, of course, this is not significant. In our first 51 ultra-low contrast patients, we compared these patients to standard control, and what you'll notice is that the spline curve for the risk for contrast is again around 1. So an ultra-low contrast angiogram is defined as a contrast volume to eGFR ratio of less than 1. What are some of the clinical outcomes for this? You'll notice that in patients who undergo ultra-low contrast angiography who have CKD stage 5, they are much less likely to end up on dialysis over 2 years. You will also notice that only patients who are in the standard control group develop contrast nephropathy or the need for renal replacement therapy. The predictors of renal replacement therapy were ultra-low contrast angiography, left ventricular ejection fraction, African American, and the pre-angio eGFR, all consistent and scientifically hygienic. We were the first to describe zero contrast PCI in this paper in the European Heart Journal, which has now actually expanded into a global effort by many different sponsors as well as interventionists to minimize the risk in these high-risk patients. When we first did this, what we would do in every patient is measure the FFR, the CFR, pre-procedure, and then after doing a diagnostic angiogram, stage the patient and use this concept of the metallic silhouette. By putting wires into the coronary arteries, we can create a reconstruction of the original image in the stage procedure. And then we would use real-time intravascular ultrasound to mark the distal and proximal reference segments, and then measure the distance exactly by IVUS proximally to distally, and use that to plant our stent. What we found was we achieved 93% stent expansion in these 31 patients. The FFR post-procedure is 0.91, which is exceptionally high, and a CFR of 3.9 with no slow flow. Once we learned that most patients do well with this, we analyzed the data, and what we found is that the pre-FFR and pre-CFR significantly improved post-FFR and post-CFR. Part of this dramatic delta is due to the high flow rates in patients with renal disease. You'll notice that in almost every situation, there was an improvement of the pre-CFR to post-CFR and pre-FFR to post-FFR. When should you do a pre-specified angiogram in patients who undergo a zero or ultra-low contrast PCI, patients who have developed symptoms of chest pain, develop EKG changes that are unexplained, have a continued CFR of less than 1.8, an ischemic FFR, RFR, IFR, or develop a new effusion? In our acute clinical events, we did not see a significant change in the GFR post-procedure, and no patients had events in the hospital. At our 6-month follow-up, we also had excellent results, which showed a significant improvement compared to a propensity-matched cohort compared to the Moran CIN risk. We've really expanded this protocol. We've now done almost 250 patients. We'll do zero contrast rotational atherectomy. We've done zero contrast CTO PCI and published many reports, especially using reverse cart. We've done zero contrast vein grafts PCI, determining when and when we don't need to put a filter in. And we've done chip PCI, including left main bifurcation, all using zero contrast. If you're interested in learning how to do these step-by-step, there's a video on Wonder Medical where Alan Jeremias and I do a step-by-step zero contrast bifurcation PCI using the Sync Vision system, using technology to its utmost utility. So what's next? Several years ago, we performed the first report of zero contrast PCI using OCT, using a mixture of colloid as well as crystalloid. As you know, we've published the data on saline OCT, which we are now using regularly for these patients with advanced CKD. And here's just an example of a zero contrast PCI case, a comparison of contrast OCT compared to saline OCT, which shows really excellent resolution comparatively between the two. We also have some non-contrast solutions, which unfortunately were hampered a little bit by COVID. This is a solution which creates a mixture of sort of commonly used products in the hospital, which provides the same viscosity as contrast and thus will provide a very similar clearance. So the clinical impact of this is that in patients with advanced CKD who require revascularization, PCI may be safely performed without contrast using imaging and physiology guidance. Thank you very much, and thank the organizers for accommodating to my time schedule. My two little girls have been waiting for me because it's Daddy's Day, so thanks again for having me.
Thank you, Dr. Ali, for being with us and for the interesting talk. Although we would have liked you to stay, we are not going to hold you back, and enjoy your day. Thank you once again. Bye-bye.
Shubhra?
Yes. Yeah.
Can you hear me?
Should I be presenting next?
Can you hear me, Shubhra?
Yes, I can hear you.
Yeah, can I show my last 3 slides?
Okay. Go on.
Yeah, sorry for this. I got cut off due to a power outage. And I'll just be very brief. So I will, where was I? Okay, so I think we were here. So I'll show you this. So we'll go back to this OCT run where it all got stopped. And you saw this. I hope we are having a terrible problem with our internet. So we saw all this. It will come up to that very tight stenosis within the RCA, and you will be able to see that. And when I saw this stenosis, I couldn't recognize that rim of circumscribed calcium in this, but it was calcium, and there it was there. And I will show you the next picture. So this is how it looked. So that is pointed to where it, the corresponding area was. And we took the NC Traveler balloon and we took it up to a 2.5 balloon to 22 atmospheres, and you can see the waste wouldn't go. So we now knew that we had to use IVL, and we actually used 6 cycles of 10 pulses each before the lesion would give way. And this is a 3x12 millimeter balloon, and you can see on the right, it ultimately gives way. And then there you can see it ultimately gives way. And then we did a post-IVL OCT run, and you can see here that it is now well expanded with the cracks, very similar to the LAD case that I showed you just a little earlier. So this is the pre and the post-IVL transformation. And then we put a stent 3.5 by 28, and you can see that the stent expands well. And we post-dilated, and we did a final OCT run, and this is going to be my last slide. So this is the this is the OCT run, and I'll try to show you quickly. So this is what you can see when the stent is deployed. And again, at the part of the vessel where it is very tightly stenosed, you can see that it is expanded, which is round about here, I think. And the rest is quite okay. So this is our final result. So the summary is that calcific lesions need careful bed preparation, and we should not try to implant stents without redilating it properly. And tram tract calcification on angiogram needs further interrogation, because not all tram tract calcifications need IVL, and you need to see where the calcium is, what is the distribution, what is the thickness, as Dr. Guliami has already showed you. And OCT is the ideal mode of imaging in such patients. And IVL is a new and effective modality of treatment. Ideally, OCT should be done in all cases where IVL is being considered. So thank you very much, and I'm very sorry for the...
That's okay. Yeah, okay, Dr. Devdata, I think they were nice cases, and we will take all the questions at the end because we are already running a bit late.
Yeah.
So could you take over the as a moderator from now? For the
you are going to be the next speaker.
Dr. Shah is the next speaker.
Dr. P.K. Shahu here? Oh, okay. All right. So Dr. Shahu is one of our foremost experts in intravascular imaging, and we have listened many times to Dr. Shahu's lectures, and he's going to speak on OCT to optimize stent implantation. Seeing is believing. He's a very senior consultant cardiologist, director of interventional cardiology at Apollo Hospital, Bhubaneswar, and I've had the pleasure of working together with him. And we have learned a lot from his cases. So it's over to you, Dr. Shah.
Good evening, Dr. Bhattacharya and all the distinct panelists and experts. In fact, are my slides visible?
Yes, your slides are visible, yes.
All right, fine. So Professor Julia has already discussed about everything, and you have also showed the cases, so I'll try to go fast in the interest of time. The role of OCT basically is to strategize and optimize. Now, this has been shown by Professor Julio that what we do, a pre-OCT and a post-OCT is to be done to know the morphology, length, and the diameter. Coming to the morphology, the most important problem is that when we have calcific lesions, as Professor Julio is telling, that the calcific lesions are like when we hit an iceberg, we don't know where we hit. There are certain case scenarios, this doesn't look very calcific, but when we did this thing OCT, you could really see that is amount of calcium in this thing that is coronary tree. If you take it over here and you see it, so here you can see that there's a chunk of calcium all around, and this is just to analyze what the pictures was like. Here you can see the calcium almost more than the 3/4 or 2/3 of the arc is there. And if you do a calcium scoring, you do a point scoring for this based on the length, the thickness, the arc. It almost comes to 3+, and when you have a 3+ point, possibly you either go for a very high pressure balloon, NC balloons, or 11, you can go for a lithotripsy. So this is one way how you can help us, how OCT can help us. Then coming to the length, we know that with the standard landing zones, as have been shown, the diameter also, we know that we have to take the different normal segments and see the diameters, both at the proximal and the distal end, and finally put the stent. Post-stenting, we have this, most importantly, is a dissection. So this is a case of a left vein dissection in which you can see that due to the wire and the guide catheter, the dissection was caused, and after a proximal stent has been put, you can see how there is a dissection, and this dissection needs to be tackled because we know that such a dissection you cannot leave, and definitely you have to put in a second stent so as to take care to take the dissection into account. So this is the left main part where you can see that the stent is well opposed and there is no other problem. And we know the OCT criteria where we can defer a stenting, that is the depth of should be intimal or medial. We have to see the angle of the dissection less than 60 degrees, the length of the flap, less than 2 millimeter, and the residual lumen area more than 4. These are the cases where you did not go ahead with the stenting. Then about apposition, if you see this case, you see this part of the stent is absolutely non-apposed. And once you used an NC balloon and you go to high pressures, now you can see these images in this case where it is completely apposed. Now, lastly, the expansion part, you can see this part of the stent is not expanded properly. So this part of the stent needs to be further expanded. And this is because of the chunk of calcium that was present. And this is how the expansion has taken place. You can see, in addition to a part which was not also opposed, you can see the expansion after this thing, that is dilatation, has been done. Now, this we know, and I have just discussed this in brief. So it is all about stent expansion, coverage, tissue protrusion, and edge dissection. Now, most importantly is that if you go beyond that, what are the differential optimal stent implantation definitions? 3 studies have come from 2014 to 21. That is the Forza trial, the CLI OPCI2 study, and Element 4 trial. The CLI OPCI2 study have clearly have their own distinct parameters, that is using MLA of 4.5 to know the dissection edge more than 200 millimeter, or to see the distal and the proximal reference narrowing. If there's an instant collapse of more than 500 micrometer, acute malapposition, and MLA less than 70 of the average reference luminal area. What they concluded was that after supposing the stent was not optimally implanted, then definitely after 1 month almost, you can see there was a divergence of the curve. So suboptimal OCT stent deployment was an independent predictor of worse clinical outcome. And if you do an OCT guided strategy, the CLI OPC studies clearly shows that we did not have all these problems. The Forza trial was something where they did along with the FFR with OCT, and they also defined the major strut malapposition, stent under expansion, and edge dissection were taken. And something that was very important to know was that using the FFR associated with a significantly higher percentage of lesions treated with the medical therapy. But when OCT was used, there was a higher instance of stenting. And of course, with OCT, there was a higher cost and higher chances of AKI. So for intermediate lesions, OCT-guided PCI costs more, yields better outcomes versus FFR. Then came the Lumen 4 trial, which showed the various criteria of an unacceptable stent expansion and the major intra-stent thrombus, untreated reference segment, what it should be, should not be less than more than 5. Major edge dissection, this is a classical, what I have told, that is more than 60 degrees or more than 3 millimeter length, and major stent appositions, small appositions. Now, when all these were compared, 3 trials were compared, it was seen that Forza criteria did not predict any dose. It was the CLI OPCI criteria and the Element 4 criteria, which shows that MSA, distal edge dissection, edge narrowing, major edge dissections, and edge narrowing were the few criteria which are most importantly and has to be seen in stent optimization. Most importantly, if you again take all these 3 studies, you'll see cardiac death, ALR, repeat MI, or a stent thrombosis was much lesser if we use the criteria and you do a stent optimization. So the take home is that stent optimization has to be done as per the criteria. A pre-stent study has to be done, a post-stent has to be done. And as per the Element 4 criteria, the CLI OPCI criteria, one has to go ahead with stents. So definitely the challenges have been made easy. Bed preparation strategies are properly done, the right stent for the right vessel, detecting and tackling post-stenting complications, identifying the cause of stent failure, and evidence-based good long-term results are there as per the last 3 studies that I've said. Thank you very much for the patient hearing.
Thank you, Dr. Shahu. Discussion will be at the end. So I'd like now to invite Dr. Shubhra Banerjee for his presentation. Dr. Shubhra Banerjee is Senior Interventional Cardiologist at Apollo Hospitals, Kolkata, and he's a prolific operator, and he's also a keen user of intravascular imaging. And Shubhra is going to speak on Light Lab. Shubhra?
Yeah, that's right. So thank you, Dr. Devdata.
Over to you.
Thank you. So I'm going to talk on the new insights from the Light Lab initiative, which was presented in EuroPCR last year. And that's mainly about the analysis of changes in decision-making procedure during OCT-guided PCI. Now, as you know, Illuminate 1 study has showed that physician decision-making was affected by OCT imaging prior to PCI in 57% and post-PCI in 27% of all cases. Also, we know from the Pan-London PCI study that OCT-guided PCI was associated with improved procedural outcomes, improved in-hospital events, that's less in-hospital events, and long-term survival compared with the angiography-guided PCI. But despite the availability of this data, the uptake of OCT has been somewhat low. And the barriers to the uptake could be that this perceived lack of benefit with OCT in PCI, and also concerns about incorporating OCT in the workflow may adversely impact the workflow in terms of time, efficiency, cost, safety concerns. So the Light Labs initiative was set up to assess the utility of implementing OCT into PCI workflow, and the study was designed and sponsored by Abbott. Now, the Light Lab initiative actually recruited 12 US centers where the prospective PCI procedural data was collected by trained field clinical engineers who were actually present on the spot. And they put the data into an format and collected the data, and that's what their job was. So it was actually a multi-phase program. It involved several phases, and only the phase 1 has been reported so far. And the phase 1 actually showed whether incorporating OCT in the workflow and following an algorithm would actually change the decision-making process in PCI. And the algorithm was similar to the MLD Max, and angiographic co-registration was done for all cases. So who were eligible? All PCIs by the participating physicians were potentially eligible, but the physicians had the last word whether to include whether to do an OCT or whether to include the patient in the Light Lab initiative. And for all patients, the lesion morphology, the lesion number, what strategy was taken for vessel preparation, the length and the diameter of the stent used, what was the post-dilatation strategy, and such other details were all collected and recorded in the e-format. And so this is the example of the e-format, and all this data were taken before OCT and after OCT. So that's an example of the format you have before you. And so a total of 2,203 procedures were assessed in this first phase. And out of them, 1,493 were excluded due to various reasons. For example, either they were referred to the surgery for surgery, or an IVUS guided procedure was done, or it was an aborted PCI. And then out of the remaining 710 OCT procedures, 106 were excluded because either the pre-PCI OCT was not performed or the post-PCI OCT was not performed. Out of the remaining 604 PCI procedures, which actually consisted of 864 lesions, again, 212 were excluded due to various reasons. So we are left with 652 lesions to analyze. And if you look at the study population, then the radial axis was used in 62% of cases, and 10% patients had multivessel disease. Most of the arteries assessed were RCA or LAD. That together would constitute something like 70%, and about 95% of the lesions were type B or C, and long lesions was present in about 45%, and bifurcation lesions were 10%. And what did the results show? It showed that OCT changes angiographic-based decisions in 88% of lesions. And most of this change in decisions, that is 83% of lesions, were actually the decisions were taken in the pre-PCI OCT, and The remaining, not the remaining, I would say about 32% were taking after the post-PCI OCT. So most of the decisions were changed, understandably. They were changed in the diagnosis and the treatment phase. And if you look at this individual parameters, you would find that the lesion morphology was reclassified in about 50% cases following the pre-PCI OCT. And if you look at the vessel preparation strategy, again, in about 30% cases, there was a change in decision regarding the strategy that would need to be used for vessel preparation following the OCT. And about 1/3 of the cases, the stent length and the stent diameter was again influenced by the OCT. And if you talk about under expansion, then about in the quarter of the cases, OCT influenced the decision whether to post-dilate the stent again or not. If you look at the individual morphologies, then you would find that most of the changes actually happened when it was a calcific lesion and somewhat less with the fibrous lesion. And for the lesions, for example, the lipid lesions, the changes were less. And if you look at the vessel preparation strategy, again, that changes were more marked in calcific and the fibrous lesions. If you look at the stent diameter, I would find that angiography actually oversized the diameter by 16%, and in 20%, 22%, it caused the other size was undersized by angiography. And if you look at the minimal stent expansion, then the angiographically optimization performed after post-PCI OCT, as given by the shaded area, is about 1/3, some 30, 35 to 40%. What was interesting was it was found that the population of lesions that followed the light lab guided workflow achieved 80% of minimum stent expansion on average. So the need for a balloon dilatation following the stent implantation was understandably less. And also, physicians performed targeted optimization in this in about 38% cases based on post-PCI OCT assessment. So, okay, so this is my last slide. And just the points that we need to remember is that OCT guidance impacted decision-making in 88% of lesions in this prospective database, and the majority of changes occurred during the diagnosis, planning, and treatment strategy derived from the pre-PCI OCT pullback. The population of lesions treated with this light lab guided workflow achieved 80% of stent expansion on average. So this real-world cohort demonstrates a clear impact of OCT on lesion assessment, procedural planning, and stent optimization. And these are the names of the hospitals and the investigators who are associated with the study. So this I end my discussion. Thank you very much.
Shall I make a point?
Yes, please.
Okay, I have two comments on the last two presentations. The first one is to remember that Illumin 4 is still with blind data, never published. So the criteria reported before are pertinent to the Illumin 3 study that was dealing with more simple lesion, while in these 2,500 randomized patients of the Illumin 4, we still are collecting data in the follow-up. So that is important to say. The other point is very practical. On the daily practice, we are confronting with an incredible spectrum of patients. Today, we saw patients with diffuse disease, renal failure, multiple vessel, CTO, is not always so simple to get this workflow respected. And the most important is being flexible when you are using imaging, and try to be reasonable. So the message is, if you can, try to do pre-PCI. If it is not feasible, try to open up the vessel to be more reliable in imaging and data. So to follow an algorithm is easy to be said, is not always possible. And if we wanted to extract the maximum information, we need to be flexible in the most complex cohort of the patients. Sorry.
Thank you, Dr. Giglami, for the excellent comments and very useful indeed. With this, could I open the discussion to all the other panelists present? And if there's any questions and anything else to discuss, please just let us know.
Dr. Shobhanan Rai, your comments, please.
I have got no comments, but a question to Dr. Julio, that particularly in bifurcation stenting, if you do a provisional stenting and do a pre-PCI OCT, how we do size of the stents? What is your algorithm for sizing of the stent when you do a bifurcation stenting provisional and do an OCT?
Okay, very important is bifurcation is dramatically changing the diameter of the vessel. Anytime you have a major side branch, after the side branch, your vessel is going to be significantly reduced. So we normally, not Dr. G, we normally size based upon the distal reference. And we try to get the most reasonable, close to the normal distal reference. What does it mean? I was showing before that today we can derive data upon the lumen and based on the EEL. So normally we are using both in this way. If you can detect the EEL, you can use the EEL and you can undersize 0.25 millimeter compared to the average of the EEL. Or if you have a big jump in sizing, you can try to use a closer to the EEL, but not to high pressure when you are implanting a stent. Then you can expand based upon the proximal reference diameter, the proximal and the carina level, and the distal based upon with a non-compliant balloon. Today, we have a spectrum of the stents in the last generation that allow a bigger range, a wider range of overexpansion. And that is very useful in bifurcation where you wanted to do a provisional stent based upon the distal reference.
Dr. Silberman, any question?
Yeah.
Any comment?
Dr. Sahu?
Yeah, excellent. Julia has already highlighted what we should do in a bifurcation. And then most of the time, as he rightly said, you should look at the proximal as well as the distal diameter. Distal diameter, you take the stent size depending on the distal vessel diameter. And proximally, you need that reference diameter for your final pot. That is, you will have to expand it to that level. And for that, you should know the expansion limits of the stent also. And keeping that in mind, you do it. And for this, OCT is very, 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 very useful. In our routine practice, when you use OCT and size your vessels, the complication rates are very, very low, and especially the dissections as well as perforations. And your overall outcome will be excellent. And for this, what you should know is you should do OCT prior to the procedure. Many of my friends or many people, they think that post-procedure OCT is sufficient. That is not a true thing you should believe. You should do it pre-procedure. If you are allowed to do OCT once, I would do it pre-procedure. So your decision making, everything helps or changes at that level. And probably post-procedure is also important. So the policy of doing only post-procedure OCT should not be followed. You should try to do it pre as well as post. I think that should be your take-home message today.
If there is there any other comments or question from any of the panelists?
I think we learn a lot today. So, for instance, we learn from the cases presented. We learn from the absolute need to limit the amount of contrast in advanced renal failure and the technical trips that we may introduce by using physiology and also by eventually diluting the contrast or saying simple that in this patient perhaps IVUS can help us. There is no full competition between OCT and IVUS. The most important is imaging to guide procedure is growing and needed to be adapted to the patient.
Thank you. If there is no other comments, Dr. Dev, should we end this session and move over to the next one? Over to you, please.
Yeah. Thank you. Thank you again, all of you, for presenting lovely cases and your viewpoints on this imaging conclave. I request Professor Golio to be around if he could for the physiology session. And we'll start our physiology session with Dr. Aftab Khan being our moderator. He's a senior consultant interventional cardiologist and director of electrophysiology services at Apollo Clinical Hospital, Kolkata. And he's been doing interventions for a very long time in our city. So over to you, Dr. Aftab Khan, for our next session on physiology conclave.
Thank you, Professor Deb, for handing over the session. And it was a wonderful session that we had in the imaging. So we move on to now to the physiology conclave. And it is my honor to be here along with two esteemed guests that are here from my city, Dr. Shivanand Roy, again, who needs no introduction. Professor Roy is again a director of interventional cardiology at Fortis Hospital at Kolkata. And we also have Dr. Hazra, who again has been a familiar face in all interventional conferences, well, nationally as well as internationally. And he heads the cardiology department and the cath lab director at the Amri Hospitals in Kolkata. So a warm welcome to all of you, both of you gentlemen. And again, if I can take the honor of introducing Dr. Neil Johnson. Again, Dr. Johnson is someone we are all quite familiar with. He is the associate professor of medicine at the University of Texas at Houston. And he has been one of the prolific users of technology to help us to guide our interventions. We know about his trials, the Contrast, and of course the Define Flow trials more recently. And Dr. Neil Johnson, it's been an honor to have you here with us. So without wasting much time, I think we'll be all waiting to hear from you.
All right, thank you so much. I'm just getting my screen set up to share. I assume everything is good for the audio visuals?
Super.
Fantastic.
Yes, I can see you, Cam. Yeah.
All right, well, thank you. A real pleasure to be able to participate in your imaging and physiology sessions. Thank you for the opportunity. These are my disclosures, but nothing that's related to the content of this talk. And what I wanted to do for me this morning, for you this evening, is to bring up and go into a word that we say quite a bit. We often talk about ischemia. And I want to put up an angiogram and a pressure tracing and ask the question, does this patient have ischemia right now? This is a patient I took care of, a very severe proximal LAD lesion. And you can see on the pressure tracings that there is an enormous gradient here, that the PDPA ratio is 0.55. And so is this lesion producing ischemia? And it's not as straightforward as you might think. You might think, oh, that's obvious. The answer is yes. But let's think about this case in a little bit more detail. This was a gentleman who was 44 years old, had no medical history, and showed up with several weeks of very classic angina, a little bit hypertensive. You can see fairly reasonable lipids. His echo had normal wall motion. The EF was intact. And he was put on a Bruce protocol where he did about 10.5 minutes and developed angina several minutes into it. And that eventually is what limited his exercise. You can see his EKG tracing both at baseline and then at peak exercise when angina was limiting him. In addition to the LAD lesion I'd showed you, he had a very large dominant right coronary artery that sent collaterals from the right to the left, even under baseline conditions. Here's his physiology. I'd showed you the baseline tracing before. You can see 0.55. And then with hyperemia, the FFR value goes down to 0.34. So obviously a very severe lesion, one of the lowest FFRs I think I have in my collection. And so it was great to hear the imaging session that just happened. I happen to be a heavy user of IVUS, and so I did IVUS guided PCI of this. You can see the stent dimensions. There was a lot of plaque burden in this vessel, despite his being such a young individual, and got a nice result, and then actually brought him back before we sent him for cardiac rehabilitation therapy. And this time he did 12 minutes on the treadmill, had no angina and no significant ST segment changes. And so the point I want to make with this case is that despite this very impressive pressure gradient of 0.55, that lesion with that dramatic reduction in pressure is not producing ischemia under resting conditions. And we know that because under resting conditions, he had no symptoms, he had a normal EF, and his EKG was completely normal. And I pair that with another case from my collection on the right-hand side, a gentleman also who had a mid-LAD lesion, no symptoms, normal EKG, normal EF. I actually sent off troponins on him and they were completely negative. And yet under baseline conditions, he has a PDPA of 0.53. And so while these lesions may produce ischemia when patients are active and doing things, under resting conditions, even these dramatic pressure gradients do not produce ischemia. And I want to think about why that happens. And this is something that we had this JACC review that came out just last month, talking about this notion of autoregulation and what the implications are then clinically when we think about making physiology measurements under resting conditions. And the notion of autoregulation can be thought of, I think, conceptually by thinking about what happens to blood flow down the coronary artery as you change the pressure. So let's start off then, for example, on this graph with coronary pressure of maybe 110, blood flow down the vessel of about 60 cc's per minute. And then let's create a transient decrease, maybe give a bit of nitroglycerin or a bit of afterload reduction through another medication. And so the coronary perfusion pressure decreases to 0.2. What happens then is the body figures out that the coronary blood flow is dropped because perfusion pressure is dropped, and it brings it back up. And so it moves from 0.2 to 0.3 under steady state conditions. It doesn't happen instantly, of course, but after a moment or two, your body figures out what to do and brings you back to a steady state. On the other hand, let's say you increased afterload. You gave fluid bolus or some other medication that increased afterload. Now you might move from 0.1 up to the other red point there, transiently increasing both coronary perfusion pressure and blood flow. But the body figures this out, of course, and it decides to reduce coronary blood flow back down to the steady state after a few moments. And so this plateau then of pressures can be seen from very nice experimental data in an animal model. You can see here under the red curve are the transient responses, and those transient responses match exactly what I mentioned, and that's that if you make a transient change in blood pressure, flow will either go up or down depending on the direction of the blood pressure change, but then after a few moments, it will change to the steady state blue curve that you can see. And over a very wide range of perfusion pressures from about 40 millimeters of mercury up to about 130 millimeters of mercury, there's very little change in coronary blood flow. That's the steady state regulatory plateau of autoregulation. You might think, okay, well, that's nice conceptually in animal models, but what about humans? And I want to emphasize that this happens in us as well. This is some fantastic data that was made at the very beginning of coronary physiology measurements with FFR, but these were distal coronary pressures under resting conditions on the x-axis. And then on the y-axis is myocardial blood flow in perfusion units, so flow per unit of tissue, cc's per minute per gram, or in this case, milliliters per second per gram. And these are from 26 patients who had normal LV function. And you can see that all the way down to 40 millimeters of mercury or so, there's a very flat line almost of myocardial blood flow perfusion. And that means that also when LV functions intact, as long as your coronary perfusion pressures are above 40, the body has the ability to auto-regulate. So what does this mean for when we make coronary physiology measurements in the cath lab on a practical level? Well, there's been an enormous interest in non-hyperemic pressure ratios. So you can see not only have we had PDPA, which is a whole cycle metric and has been around for many, many years, but over the last 5 to 10 years, really every device manufacturer has brought out some kind of non-hyperemic pressure ratio that looks at a subcycle, and that's something that has received a lot of attention. As far as we can tell, all of these various non-hyperemic pressure ratios have the same prognostic value. This is some great data from a collaborative study from Korea, Japan, and China, looking at many different vessels that were deferred. So they just had a natural history study, and they took the pressure tracings and ran them through 3 different NHPRs, IFR, DPR, and RFR. And as you can see, the natural history prognostic value is identical among all of them. The challenge with resting measurements, as I hope I've made clear through my case examples, as well as by talking about autoregulation, is that for stable patients, as long as your coronary pressure is above 40, that doesn't tell you anything about the potential or lack of potential for those lesions to cause ischemia, because the body can always auto-regulate and make things stable. And so when you're dealing with outpatients who are not undergoing an acute coronary syndrome or cardiogenic shock or something like that, where you've clearly moved into a zone where auto-regulation doesn't apply, what this really means is that resting flow, resistance, and coronary pressure don't tell you about what's happening under conditions of stress. And so that's why I think the American guidelines continue to really strongly favor fractional flow reserve. You can see here some of the text that came out a couple of years ago, bringing up that FFR really remains the reference standard because of its validation. And I would say it's not just a validation issue, it's also a conceptual issue. And that's that only fractional flow reserve is the ability to remove conditions of autoregulation and to try to understand what happens under stress conditions. And so this is, to finalize things, really a bit of a conceptual issue, right? If you think about when we do a lot of our measurements or when we meet patients, they're often like this gentleman here on the right-hand side sitting in front of us in the emergency department or clinic, and they're kind of smiling and happy and, oh yeah, I had something that happened to me last week. And when we do our stress testing or when we do our cath lab testing, a lot of them don't have symptoms at that moment, right? And so what we're trying to do is to measure and understand the physiology that happens to patients then when they're actually exercising or doing something that brings out their symptoms. And so if we make resting measurements, not only are those measurements not then causally related to the symptoms that are going on, but because of autoregulation, the body actually eliminates our ability to understand the connection between those two. And that's the kind of contradiction that I wanted to get us thinking about today. All right, thank you so much for your attention. It's been a pleasure.
Thank you, Professor Johnson. It was a really, these are really insightful. It was an insightful talk, and it brings up a lot of questions. If I could just start off with, from our physiology days, we've been taught about the coronary flow reserve as being the driver of blood flow to the myocardium. And the pressure wire was usually thought as being a surrogate marker for the coronary flow. In your defined flow, you have shown that you still would say that the coronary flow reserve has not really helped us out, and FFR still remains the gold standard. So how do you explain the dichotomy between the CFR and the FFR? And what exactly do you do for a patient who, for example, has a negative FFR and a low CFR?
It's a good question, and I'll bring up 2 aspects of that. The first is that the only things that I think we're able to do with revascularization are to improve patient symptoms and to reduce the risk of myocardial infarction. That's been the only signals from a large body of trials. And those 2 things actually happen for different reasons. So myocardial infarctions largely happen because you have hemodynamic stresses against a vulnerable plaque. And the best metric we have about those hemodynamic stresses then are the epicardial pressure gradients. And so large focal gradients within the epicardial arteries provide a large hemodynamic stress against the plaque that's there. The more plaque that's there and the more vulnerable features it has increases the risk of that hemodynamic stress causing plaque rupture and failure, and that's the trigger for myocardial infarction. All of that has nothing to do with how patients feel. I can show you any number of examples of patients I've taken care of who've had asymptomatic large focal epicardial gradients who then go on to subsequently develop myocardial infarctions down the road. Again, so it's not a symptoms issue. The other question then so making flow measurements there is not very useful. And in fact, the more flow there is, the more pressure gradient there's going to be, and the more hemodynamic stress you're going to have against that lesion, causing it potentially to rupture down the road. On the other hand, then what about symptoms? And symptoms are complicated, not only because there's a lot of vagueness in the way patients present or the way patients describe what's happening to them, but also I would say because there's really two different kind of mechanisms for it. One is the classical kind of symptom like the patient that I showed you there, where you have a very large area that under stress conditions doesn't get enough blood flow, really transmural ischemia under stress conditions. And that is something that actually makes up a minority of the angina that's out there in the world, but certainly can be well understood by making epicardial pressure measurements. The other one, that the clinical scenario where you describe where someone has a negative FFR, but yet they have symptoms. The most common reason that happens is because the blood flow in the muscle has to go from the epicardial layer down all the way to the subendocardium. And it's really that subendocardial layer, that inner layer against the LV cavity, that's the most susceptible to underperfusion for a variety of reasons. The LV filling pressures are higher. It only perfuses in diastole, so tachycardia takes away its supply. And then the perforation vessels that go down get compressed during systole. And so as a result of all of those features, even if you have adequate epicardial blood flow and not much epicardial pressure gradient, some of those patients are going to have subendocardial hyperperfusion as a metric for their symptoms. And that's something that we don't have easy tools in the cath lab to understand, except perhaps conceptually to realize that most patients have that as their mechanism if they don't have an epicardial lesion.
I don't know, possibly some of the ladies that we see with chest pain and normal coronaries, INOCA possibly this could be one of those subsets, or the myocarditis that we probably see. I think possibly these could be the subsets that.
Or another classic one we see all the time are patients who have severe aortic stenosis, right? But normal coronary arteries that have chest pain. The reason they're having chest pain is LVH outstrips supply to the subendocardium, high LV filling pressures. When they get a bit of tachycardia and reduced diastolic perfusion time, that's what happens exactly.
Yeah. Dr. Roy and Dr. Hazra, comments or questions from your side?
I have a few very interesting topic, basically, and I have a few questions. And first of all, it is not only the symptoms which which we treat actually. In the earlier ASIP study showed that the ischemia guided therapy versus the symptoms guided therapy, the ischemia guided therapy always reduce the MACE. So that is one thing. And number two is, it is seen that if we know that FFR is a gold standard, and in all the resting parameters, particularly they are not dependent on the flow like FFR. So in cases where there is increased flow, as for example in the left main disease or in the proximal LAD disease where there is a focal lesion, their FFR would be more significantly positive, where the diastolic resting parameters like RFR, IFR would be negative. So what should be the criteria then? Should we go with FFR? And it is also seen in some studies that when somebody goes by the resting parameters like IFR, the MACE rate is reduced than the FFR guided therapy. So is it that FFR overestimates the ischemia, or the resting parameters underestimates the ischemia? What is your opinion about that?
Well,
focal
again,
and
yeah.
Yeah, LMCA or LA deletion. Sorry.
I would come back, I think, to 2 points. The first is that because of autoregulation, all of the resting measurements that we make have nothing to do with ischemia, right, in stable patients. And so no matter what the RFR or the DFR, and listen, I published a whole paper about that stuff, no matter what those things say, none of it tells you anything about ischemia in stable patients because of autoregulation. It's only under conditions of stress that you're able to say something causal about the relationship between the pressure measurements that you're making and say the symptoms that patients are having. The second is how to understand the clinical trials that have been put out there. And the challenge with clinical trials for comparing two things is you really need to focus on the areas where they disagree. And so the right way to do those trials is to measure both a resting metric and a hyperemic metric, and then look at the cases where they say to do two different things. So for example, some of the cases you bring up, boy, all right, we have a mid-LAD lesion, the resting measurement is not very much, and the hyperemic measurement is really, really bad. All right, they're telling us two different things. Those are the kind of cases that need to be studied. And what we've known from a lot of different studies is that in about 4 out of 5 lesions, the two measurements will tell you the same thing, right? Both resting measurements and FFR will be negative, or resting measurements and FFR will both be positive. And so those cases of agreement don't allow you to understand what happens in the discordances, and the discordances are the only thing that matter for allowing us to figure it out. And so unfortunately, the way that those trials were designed was done in a way that doesn't give us insight into which one we should use when they tell us different things.
Yes.
Professor Hazra, any comments from your side? Or yeah, so I think we'll then move on to Professor Hazra talk. And he's going to be talking on improving clinical outcomes with FFR in PCI, evidence-based treatment.
No, it was a little different, ambiguous coronaries. Anyway, these coronaries are the patients, whether it is SCS, STEMI, or chronic stable angina, they may look similar, but all are different. And can you see my slides, Sapta?
Yeah, you're visible.
Yeah. So he is the first man to undergo angioplasty. He's still kicking. In 2017, he was 78 years. And you'd be surprised to know that his angioplasty was done by a person who has 6/6 visual acuity on good QCA. He did not require FFR till he had a restenosis in 2000, and he used FFR, Barney-Mer, and that time FFR was 0.83. And Barney-Mer ignored the FFR, and he did angioplasty, post-balloon angioplasty, and is still doing well, and he is surviving. So some people still do not believe FFR like Barney-Mer. Some people believe in totality. So she is the lady, a very popular lady in India, as well as abroad. Mother Teresa had her angioplasty done by none other than Paul Turnstein. And that time there was no FFR, and she was kicking for many years, and Paul became very famous all over. And Paul also became very famous with the beauty. Now the FAME trial had become famous after this FAME 1 and FAME 2, but it has been defamed recently by ischemia trial, by Greg Stone's analysis, Eliano's analysis in Europe PCA, that if you just go by angiographic analysis or angiographic treatment of coronaries, you prevent 21% death. And this meta-analysis includes 18,000 patients. And Flower MI trial, where Neil Johnson is one of the investigators, also will agree with me, the complete trial. They ignored the FFR. And it is very, very painful to know when every trial previously said that it should go by FFR or IFR, and the recent trial, they said just opposite thing. But as a whole, if your FFR goes down, if you have a lower number and more symptoms, you get benefit out of angioplasty. And these numbers should be reproducible. Like if you repeat the FFR or IFR or DFR, QFR every time in the same patient, in the same coronary, the number should not vary much by just 1 or 2 here and there, but it should be repetitive, same number all the time, then you can rely your tests. Now in the future, you can have this kind of combinations of investigations like OCT and FFR. That will obviate the need for your another wire. Now, the problem with FFR and IFR, you know that this 30 millimeter of FFR where IFR were, RFR were, this is a blind spot. You cannot have anything from here. So this sensor is here, but that's why you are looking for this microcatheter based FFR, and Supreme study has validated that this 2.5 millimeter just behind the marker, you can obviate this blind spot. So it can be done on existing wear, it can be done on multi-vessels. So this is the beauty of microcatheter based FFR. Now, as Dr. Rai was mentioning, if you combine a sweetheart and defined fair study, and in this study, if you do FFR in less than 60 years versus IFR, 12% of patients do get extra revascularization, maybe unnecessarily, and especially in younger patients. So FFR is not that good in young, maybe IFR and RFR is better by 12%. And when you should avoid, that doesn't make sense in 2021, in higher tritile of coronary lesions, like 90 and 99%, more than 50% left main lesions in young who are symptomatic, proximal LAD more than 70% in young who are symptomatic ISR, slow flow lesions, and culprit ACS. So here is my patient, and he had lesions in the LAD, which looks ambiguous, whereas it is hazy. And if you do the FFR to the LAD, it is 0.76 and it is positive. And it was reproducible, repetitive, and accurate. So that accuracy brings the mesh reductions. And these are the lesions of orbital trial, Rasha Lamy. These are exactly the same patient we see day-to-day life, and all look ambiguous, non-ambiguous, critical, non-critical, left main, proximal LAD, bifurcation, etc., etc. So this complexity can be at the ostium of the right coronary, where the flow is mainly systolic. In the left, it could be in the bifurcations, proximal LAD, where the flow is mainly diastolic. So you need to have full cycle length of FFR or IFR. That is possible only with RFR. And there are problems with FFR or any physiology. For like seizure lesions, we have a problem. There is no outcome study, but this pullback is possible with IFR and RFR and ACR. This co-registration also help us to minimize the strength length, to minimize the metal load. SBG is predominantly dominated by biology rather than physiology, so it's not very useful, but there's some outcome data. Ostia, we have outcome data. So we are also heading for some more newer things like CFR and IMR, when this microvascular dysfunction, if you believe that micro dysfunction exists, it is helpful. But if you are non-believer, there are many people who do not believe in microvascular dysfunctions. And if you believe, then it is possible to make you convinced that perhaps in some patients, both FFR, IFR, and CFR and IMR are also important to take a call. Now here is the lesions. It looks very, very ugly on an angiogram, a calcium nodule perhaps. But if you do the RFR recording, it is negatives. So there are a lot of surprises in life, and it is possible only when you do the physiology test. Now, if you do the IVAS here and OCT here, definitely this man would have undergone an angioplasty by some criteria like MLA or MSA. You can justify your PCI. And many of these patients who has undergone angioplasty in the past in many trials, they have residual angina. Perhaps we have missed the ambiguous lesion by angiogram. Perhaps could have had a different picture. But whatever has happened, happened. So what is the current status of treating chronic coronary syndrome, or chronic stable angioedema, or SIHD? This is the meta-analysis of large number of patients, 21% cardiac death. And if you look at these trials, the MAS, RITA, and COURAGE, these are not FFR based. In spite of not having FFR or IFR physiology, there is 21% reduction of cardiovascular death. Now, this is again ischemia trial. Winner is acute complete revasculations, anatomical versus your FFR guided revasculations. So ischemia trial sub-study presented in PCT and your SEC 2021, that angiography wins. Why only FFR failed versus angiographic? Sometimes if you have microvascular dysfunction, the Neil Johnson has presented in TCT Connect that if you have CFR less than 2 and FFR less than 8, perhaps these are the people who will benefit the most, and there will be no ambiguity. We also have the new software which is launched in Europe, This Coroventis, this Giadali has demonstrated yesterday in OPCI live that in equivocal IFR or FFR, you should go for other parameters like CFR and IMR. You just inject 3 cc saline, and this thermodilution catheter will take care of these things. We should also look for this long-acting adenosine, because these younger people, they're more responsive to adenosine because of the caffeine may interact, so on and so forth. So you can give just one bolus injection of regadenoson, and you can estimate the FFR. Ischemia trial or other trial, they have ignored the FFR because the number of people who has undergone physiology is very minuscule. And here is another patient, like this lesion in the LAD, it looks ambiguous. This circumflex looks okay. This is ACS, and IFR is 0.87 in LAD. So there are surprises in life where you can find that these lesions are very significant, and you can just rely on either FFR or DFR or QFR or RFR. You can go ahead with your stenting. When these things are negative, you must take help of imaging like OCT. The OCT shows less than 2 millimeters square, a vulnerable plaque, a plaque rupture, a thrombus there, you should fix these lesions. So perhaps the good vision, 6x6, accurate physiology and imaging is very important to take a call on each and every patient. You have to bring this patient, you have to put this patient on the other side by a heart team. So it is not competitive, and sometimes it's complementary. So help of other investigations like your angiography, QCA, IVERS, and OCT, and maybe in the future, you should take help of the lipid content that needs spectroscopy to know the lipid content. If the lipid content is very high, FFR negative, perhaps you can fix this coronary by putting a stent. So that is the concept of vulnerable plaque, or you're fixing the vulnerable plaque to prevent another acute coronary event in the future. Maybe in the OCT, you can see some features which are more vulnerable for acute event in the recent time. You can fix these things by putting a stent, by observable or conventional stent. So ladies and friends, let me conclude here. Nothing is like a gospel truth in science. You can take help of many things, and perhaps that will help the patient, not your imaginations anymore. Thank you for your contribution.
Thank you, Professor Hazra. I think for want of time, we'll just move ahead to my talk, and we can come back to discussions after all the 3 talks, please. And please be around here. So if you can unshare, I will.
Yeah, I think I have unshared.
Yeah, so. So are you able to see my slides?
Not yet.
Yes, yes.
Okay. So my talk is basically going to be on the use of FFR or non-hyperemic pressure indices and ACS. So
we can't see your slides.
Oh, my slides are not. Just one second. I'll just have to.
Sir, first share your screen.
Yeah, just one second. I think there's some. Yeah. Yeah. So are the slides visible now?
Yes, make it a slideshow.
Yeah.
Yeah.
Right. So I'll be basically talking about the FFR or non-hyperemic pressure indices in ACS. And I think this is 2 things that we all know from now, that when it comes to ACS and when it comes to stable coronary artery disease, I think we have enough data to suggest the use of FFR or non-hyperpressure ratios as decision-making tools in stable coronary artery disease. But yes, in unstable angina and ACS, where it comes to unstable angina or myocardial infarction or non-STEMI, there are reasons to believe that this use of these tools may be a little unreliable. And the reason for this is something that we all know, that once there is an ACS, there are certain changes that happens both in the intraluminal space as well as there is extraluminal compression. For example, when you have a patient with a myocardial infarction in the LED territory, we know that there'll be hyperkinesia in the other walls, or compensatory hyperkinesia, say from the circumflex or the RCA territory. And this could be a reason for potentially increasing the blood flow in the non-culprit arteries. But there are other methods which cause a reduction in the non-culprit coronary hypertonic flow, of which one is the use of release of endothelins and the other cytokines, as also the blunted hypertonic response, and something that Dr. Johnson has also referred to, an increase in the LV-EDP or increased pressures in the myocardium would cause a compression of the myocardial coronary supply. And therefore, this is something that has been mentioned earlier. So if in a non-culprit artery that you tackle or you interrogate during the ACS, you may get an FFR which is higher. And then later on, once you get these patients back, you may get an FFR which is vastly different. So there has been a study that has been done, and this is a study level analysis of multiple small studies that have been done, which have looked at stable coronary artery disease and ACS. And most of these studies have shown that the abnormalities in this flow reserves, whether you do an FFR, it usually is worse off when you have an ACS compared to a stable coronary artery disease. And then a pooled analysis, a patient level analysis was done by Yaver, and this was a huge study with a lot of patients, and they looked at 5 major studies. And this was a patient load of almost around 8,000 patients. And what they did was that they looked at stable coronary artery disease vis-a-vis ACS, and in patients which were treated, and when they looked at the deferred vis-a-vis ACS, to defer a non-culprit lesion in ACS, stable coronary artery disease. Again, this brings back to the and there was this small combined FFR OCT design that was presented, and what they looked at is, and patients had an ambiguous result when they had an FFR which is more than 0.8 in a non-culprit.
Unmute yourself, Bhakta.
Sorry, I think we lost your touch there. Yeah, so when we looked at this lesions, they found that patients who had...
Share your screen again.
Oh, God. I'm sorry, I got logged off. Is this where we were?
Yeah. Go ahead.
Yeah. So I'll just make it full screen.
Go to play. Yeah, press the play. Yeah, play button.
Yeah, I know it's got hidden between this.
Yeah.
I'm sorry for that. So when we looked at thin cap fibrosarcoma, they found that those patients who had a TCFA, they had worse outcomes as those patients without a TCFA positive. And this is what they looked at on an OCT. Anyone who had a thin cap fibrosarcoma which was less than 65 millimeters, well, these were the patients who had worse outcomes. Now, this imaging was done in a group of patients who are diabetics. And well, this is a small study which does raise a lot of questions and probably provocates further thought. Well, this data again looked at the planned versus deferring versus intervention in a non-culprit and an ACS. And what you look at is that there's not major difference in myocardial infarction or death, but the differences was basically driven by unplanned revascularizations. And this included both interventions as well as CABG. And again, I think this is something that we all know. When you have an FFR, which is done in a patient with a STEMI, well, we know that when you evaluate these patients, and this was again the data that was produced as a part of the analysis in the reduced MI trial, there were a lot of patients who would have a significant lesion, but you would have a false negative. And this is as much as 15% of patients where the lesions would be negative, but these would be a false negative. Whereas if you had, and the reason for this, I think, as we discussed earlier, it is because of the changes that happen both inside the lumen as well as the extrinsic compression that happens in patients when they have an acute coronary syndrome. And when it comes to IFR, the same study had seen that there are more false positives when you have an acute non-culprit vessel that you tackle during a STEMI. And the reason for this is often related to, as Dr. Johnson was saying, to an increase in the resting flow. So these patients, when you have, unlike a patient with a stable coronary artery disease, when you have an ACS, the non-culprit vessels also show an increased resting flow, and this can affect the outcomes of their measurements. And we know that, as I said earlier, there is an adrenaline dive that happens during the ACS, and all of this could affect the resting flow in these patients. The other problem often happens is that when you have an ACS, sometimes there is an ambiguity about the lesion that is there. So we often have an ambiguous lesions, and we often may not be able to identify which is the culprit. And if you were to sort of intervene, or you were to interrogate a lesion which is an ambiguous lesion, and then you would end up having a higher MACE rate. So you may end up not doing a lesion which is actually a culprit and leave it, assuming it to a non-culprit. Vis-a-vis, if you had a clearly defined culprit lesion, then in these group of patients, probably the MACE rates were not any different. So this brings back certain concerns that we have with an FFR. We know that in stable patients, as compared to patients with an ACS, there are shifting physiological boundaries. We also have heard that there's a higher prevalence of vulnerable plaques. And as I said, we sometimes can make a mistake in identifying the culprit stenosis, and all of which can translate into either a negative FFR if the culprit vessel is mistaken, or sometimes a false negative FFR result also. This is what, again, coming back to the data that we talked about earlier. So in an acute phase, the IFR is usually decreased, but it often does increase, but not in a very significant fashion. But in an acute phase, the FFR is often elevated, and it tends to come down in a significant fashion. So again, this brings back a point, and this is something that Dr. Johnson was also talking about, the core difference between a CFR and an IFR when you look at the coronary flow reserves as well as the FFR. And Dr. Shubharan Roy was probably referring to this defined flare sub-study where they looked at FFR vis-a-vis IFR. And they have said that in patients, when you look at the FFR measurements as compared to an IFR measurement, in an FFR deferred patients, the MACE was significantly higher in the acute coronary syndrome non-culprit as compared to the stable coronary disease. Whereas in the defined flare sub-study where the IFR was used, the curves were not really, the Kaplan-Meier curves were not really significantly different. Between the stable and the ACS, not much of difference in the major adverse cardiac events. Again, similar to what Dr. Roy was referring to, when you have the same sub-study of the defined flare has again shown that when you had an LAD deferral with an IFR, you had a lesser major adverse outcomes. Whereas if you did an FFR, you had major adverse outcomes. And this was for the LAD deferral as compared to a non-LAD deferral where there really was not much of a difference. Again, these are a retrospective analysis and not a prospective trial. And one has to be aware of the limitations of this analysis. Again, as I said, the IFR data has shown certain advantage in terms of MACE, whether it comes in terms of myocardial infarction, revascularizations, or total MACE. And this is mostly for the LAD deferral and not so much for the non-LAD deferrals. So just to conclude, I'll just share one of my slides of one of my cases. A young lady, dyslipidemic hyperemic, came with a chest pain of 8 hours and had an acute inferior wall infarct, no real conduction delay or right ventricular infarct, EF of 50%. This is our angiographic right coronary cutoff that was there. And this is a non-culprit LAD. And you can see that there is an ambiguous lesion here. In the cranial view, it looks a bit more than what we would like it to be. So this lady was revascularized for the primary angioplasty was done, and her right coronary artery was revascularized with 2 stents. And we managed to get a good flow into the right coronary artery. The contrast load was low, so we finished with 90 ml. So that gave me a chance to interrogate the left system, and the left LAD lesion was at an RFR of 0.73. Now, this is important because if I had a borderline value, I think we would again have discussed whether one should intervene or one should wait. A value of 0.73 was really in a severe zone. And again, we had this pullback gradients where you had the lesion step up in the mid part and in the proximal part. So this lady was fixed easily with a stent in the proximal part of the LAD, and the repeat RFR showed a good result in the distal LAD. Again, coming back to what Dr. Hazar was just discussing, this trial, the Flower MI study recently has created a certain sort of discussion again about the benefit of FFR guided vis-a-vis an angiographic guided. And Dr. Johnson is again would be there to comment on and help us. But what we know from this trial is that, well, the FFR guided study did not, however, show a benefit over angiographic guided strategy. But again, given the wide confidence interval, there's no conclusive evidence. The investigators are going to follow up for 2 years. But what we know from this trial is that there was 1/3 patients who did not end up requiring a stent. And I think that's what we also need to understand, that we also end up not putting stents in many patients whom angiographically would have put up a stent. So to conclude, I think an ACS, I would still say physiological assessment of the non-culprit lesion is safe. Well, it is safe to defer the non-culprit lesions. It is non-inferior for sure. Is it superior? Well, when you look at the data, when we have data from the Dynamic 3 Pramalti or from the compare acute trials, we know that probably it is superior. Well, FFR, I have preferred an IFR. We heard Dr. Johnson, who still swears that FFR would be better. And I think the further direction would be to, of course, apply imaging in some form to identify a vulnerable plaque in those lesions that we have deferred, especially those supplying a huge area of the myocardium. So I'll stop here, and I think for want of time, I'll move on to the next topic, and I would invite Dr. Kuntal Bhattacharya.
Yes,
he's a consultant interventional cardiologist at the Rabindranath Tagore International Institute of Medical Sciences. And Dr. Kuntal will be speaking on the Compare Acute trial, the 5-year follow-up.
Thank you, Dr. Khan, for your introduction. I have learned a lot in this 2 hours journey from the expert. So the Compare Acute actually published in 2017. So we don't have 5 years follow-up data yet. So it is a 3 years follow-up data I'm going to present. So there are some limitations in FFR for acute STEMI patient for non-culprit artery. And we know that the results are not matching in all the trials. You can talk about complete, you can talk about Flower MI. So let us see what are the data we have with Compare Acute. It is a randomized trial of FFR-guided complete revascularization versus infarct-related artery-only treatment in multivessel STEMI patient, and it was published in 2017. So now we have 3 years follow-up data. So the recruitment actually happened over 24 countries, mainly in Europe and Asian countries. What we see, approximately 50% of the STEMI patients have multivessel disease at presentation, and 50% or more diameter stenosis is one or more non-infarcted artery. And always the operators are actually in dilemma after opening up the infarct-related artery, whether he will open it or not. So what and when to do with these non-infarct-related artery lesions remains an unresolved clinical dilemma. And still all these trials cannot guide us properly that when we should do it and whether at all we should touch that. So we have experience of dynamic primality. Dynamic primality shows FFR-guided revascularization in intermediate lesion and lesion more than 50% is probably better. If you consider the target vessel revascularization, it is definitely better, but maybe the all-cause mortality and all these things are not significantly reduced in dynamic primality. So this Compare Acute trial was designed, and total 885 stable multivessel patients were randomized. So it is very important all patients were stable, so not requiring any inotrop, no features of pulmonary edema, etc. And the trial design was 1:2 randomization. So the first group was 295 patients, where acute FFR-guided complete revascularization of non-culprit artery was done following the culprit artery tackling. And the other group is having 590 patients, where infarct-related artery-only treatment was done. And all those patients, all 590 patients, post-procedure, post-primary procedure, they have done an FFR, but consultant or operator were blinded from the FFR values. Some of the patient requires post-procedure angioplasty within 45 days, and that was elective procedure, and that was the discretion of the operator. So within 45 days, whoever required elective angioplasty, those procedures was not counted in the analysis. And the patient were followed up at 1 month, 12 months, 2 years, and 3 years. So the exclusion criteria is important. So all left main diseases was excluded. Patient with subtotal total occlusion with severe stenosis with TIMI flow less than 2 are excluded. Suboptimal result or complication after treatment of infarct-related artery like major dissection and etc. excluded. Severe valve dysfunction and patients with class 3 and class 4 KLIP are also excluded. Now, the non-infarct-related artery, particularly the artery diameter when it is more than 2 millimeter and the angiographic stenosis is more than 50% by QCA are included, and all the patients were post-TIMI. So the primary endpoint was the composite of all-cause death, recurrent myocardial infarction, recurrent revascularization, and cerebrovascular events at 12 months follow-up. Similarly, all patients were followed up for 3 years. This is very important, this endpoint education that I already mentioned. The clinically indicated revascularization was defined as stenosis more than 50% by QCA with one of the following, that is recurrent angina pectoris, ischemic ECG changes, ischemic non-invasive or invasive test findings, all presumably related to the target vessels. So all post-procedure requirement of the target vessel revascularization should have this criteria, or patient may not have any symptom, but angiographic stenosis if it is more than 70%. So all baseline clinical and demographic parameters were matched, except the infarct-related artery group has more smoker, so it is a little bit statistically significant. The baseline characteristic like location of the MI, this primary PCI done within the 6/12 or more than 12 hours are matched. Most of the patient has double vessel disease. Almost 2/3 of the patient has double vessel disease in both the groups, and 1/3 of the patient has triple vessel disease. The procedural data are also matched in both the groups. So the mean reference vessel diameter was around 3. 50% or 45 to 50% patient has got RCA lesion, and other 50% lesion was distributed among LAD and LCX. Very few left main lesion, and you know that left main lesion are excluded. Now the procedural data, the mean non-IRA lesion per patient was 1.54 in both the groups, and pre-procedural TIMI flow in case of most of the time it is 98%. In non-culprit artery, you can see it is 98%. This is the procedural details. So the patient with FFR guided complete revascularization, which is 295 patients. Out of those, 55% patients has went for angioplasty, complete revascularization with FFR guidance, and the other group does not require any angioplasty, and it was excluded by angiography. The mean index procedure time was 65 minutes, so only 6 minutes more than the infarct artery only related group. And the mean contrast volume requirement is only 22 ml higher. So it is not, it is clinically it is not significant, but statistically it is significant. And the median hospital stays was not different in both the groups. So this is the FFR outcome. The FFR in both the groups are mean FFR was equal, and it is not, there is no difference. It is around 0.78 to 0.79. And positive FFR value that is less than 0.8 was taken as cutoff. In both the group, it is around 50%. So this is the primary outcome at 1 year. You can see the hazard ratio is 0.35, and the FFR guided group has less primary outcome, that is 7.8% vis-a-vis infarct artery only group, where patient were not done any procedure after the tackling of the primary lesion. So this difference of overall MACE is mainly contributed by the repeat revascularization. You can see this repeat revascularization by PCI or CABG is much more higher in infarct artery only treatment group vis-a-vis the complete revascularization group. And this is the main contributor for overall MACE calculation. The secondary endpoint, you can see this net adverse clinical event is also higher in case of infarct related only artery group vis-a-vis the complete revascularization group. And this is the FFR of the target vessel. If you consider the FFR values of all these non-infarct related arteries, you can see among 50% of the patient has got a value either close to the 0.8 or just above the 0.8, and the mean is 0.82. This is the data at 2 months. It was presented in TCT, and you can see the all vessel. If you see the target vessel revascularization rate is higher in case of lower FFR group than the higher FFR group. Similarly, the MI at 2 years is also significantly higher in case of low FFR group. If you see the relation between the events with the FFR, then it is not a linear relationship, but you can see there is a jump of or doubling of the percentage of repeat revascularization. If you consider the cutoff FFR of 0.8, you can see only 14% patients require repeat revascularization when FFR is 0.8, whereas 32% patients require repeat revascularization when the FFR is less than 0.8. So this is the 2-year follow-up data with we can see the tertile of FFR. So when FFR is close to or FFR is less than 0.8, then, and if you do not revascularize those vessels, then the TVR and all these death rates are higher. This is the 3 years data published in 2020. It is published in JACC. You can see this, the divergence of the graph is remained similar at 2 years and 3 years. So there is significant benefit if you target your non-infarct-related artery with your FFR guidance. So to conclude, in patient with STEMI and multivessel disease treated by primary PCI and medical treatment, an FFR measurement in non-infarct-related artery immediately after primary PCI shows a nonlinear and inverse risk continuum of MACE. This is very important understanding. This finding extends the prognostic value of FFR to the acute setting in non-culprit and reinforce the role of FFR in decision-making SES. So probably IFR and RFR may be the resting parameters may be more helpful in acute coronary syndrome when your hemodynamics is not suitable to do the FFR and analyze the FFR value. Importantly, the worsening of prognosis is demonstrated around the cutoff value of 0.80. It is established in all the other studies. In patients with STEMI and multiple vessel disease, FFR-guided complete revascularization is more beneficial in terms of outcome and healthcare cost compared to IRA-only revascularization at 36 months. So thank you.
Thank you, Kuntal. I'll just have to ask the organizers and Dr. Deb if it's okay for us to continue since we've already exceeded time, and Dr. Neil Johnson, if he'll be around, if it's okay for him to be available for a little more time.
Sure, I think you can carry on for another 10 minutes.
So for want of time, I think we've had 3 lectures, and I would request Professor Shivran Roy to have, if he has any comments or queries about the presentation by Dr. Hazra. And then I'll request Dr. Binayak Deb to have a comment or query about my talk that I've given. And Dr. Hazra can have a query or a comment on the talk given by Dr. Kuntal. And of course, Dr. Niels is there. We can always have a question to him during these 3 talks. So Dr. Shivran Roy first.
First of all, I must congratulate Hazra for his excellent deliberation. But I have some very small question that nowadays, without using adenosine, contrast can use as a partial hyperemic agent, and it can be assessed by contrast angiographic FFR with a flash software, and it has been seen that this contrast derived angiographic FFR is much superior than the resting parameters. I mean, like RFR and DFR. Opinion of Hazra, Dr. Hazra.
Yeah, contrast FFR can be done, and it has not been externally validated in large randomized clinical trial. Only one thing, you have to have a lower cutoff like 0.7 in contrast FFR, unlike 0.8 with your adenosine FFR. But contrast FFR, whatever you give in coronary, whether papaverine, adenosine, regadenosin, contrast, cold saline, there will be some changes in the coronary. Now the question is what value you take to translate these informations into reductions of MACE and cardiovascular death. So far, FFR have more data, but as I said, FAME1 and FAME2 become famous up with FFR. A lot of newer data that perhaps whatever you see is critical. Like you see angiographically critical, fix it. If you see FFR critical, fix it. If you see OCT critical, fix it. If you see IVUS, you fix it. If you see vulnerable plaque critical, you fix it. So in one particular patient, one may be ambiguous, then you have to take help of other.
The point is, as because in every case you have to use a wear or an instrument or everything, it increases cost. But in this angiographic FFR, you can have, it is just wireless, and you can depend on angiography. That is, you can be very user-friendly in that.
I think we are talking two different things. One is QFR, which is wireless from I think Meditech or something like that. We do practice in our hospital. So QFR is you have 3 cycles, 3 bits, and you have to take 2 views, and on angiography you can have these informations. And another thing, you have wire and you inject contrast. In those cases, you can have similar FFR like figure, like 0.7. Neil can have your comment on this.
Yeah, it's interesting. You know, the curve shows that contrast bolus is about like giving 4 mics of adenosine. That's kind of a rough envelope, back of the envelope kind of calculation. So it's not like high dose adenosine like we recommend for full FFR, but that's kind of roughly how much you get with just a quick injection.
Right.
Dr. Deb, any queries or any comments on my talk?
Yeah, I mean, the FFR, traditionally we knew that it was not, it was meant for stable patients, and not so much in the ACS patients where we need to defer things. So what is your impression on this about the FFR in the culprit arteries and ACS patient?
Yeah, so I think I was just looking at the data, and the data from the DIFFER IFR trial, as I said, it's a subgroup analysis that has shown that probably in the proximal LAD in a patient with an ACS. So we know for sure that as compared to stable patients, deferral of patients of the non-culprit artery and ACS usually has a worse outcome, and it's often better to fix these lesions if you have a segment lesion. Now, comparing to FFR versus IFR or none of those non-hyperemic indices, as you showed in an acute phase, sometimes it is difficult to get a value of FFR, which is significant. And I think that's where I'll ask Dr. Johnson also to comment. Now, what is his level? I mean, there are certain talks that there are certain groups of people who do believe that from the 0.84 in an acute setting, you should probably go up higher. You should go to 0.08 to 0.84 probably in an acute setting. So what is your practice, Dr. Johnson, in a patient with a non-culprit artery in an ACS situation?
It's a great question. And I'll tell you that a lot of it depends on the logistics after I finish treating the culprit vessel. So it depends on how much contrast, how much radiation, time of day, other patient workflow, and then also some specific issues with the patient regarding ability to come back for second procedures. And we also have a lot of uninsured patients here in the United States. And so ability to pay for second procedures as well. If the procedure has gone very smoothly and we haven't used much contrast, I can move right on and do non-culprit vessel physiology. I use FFR, I give adenosine, that's not an issue. I also have the policy for some patients who I don't think are going to be able to come back, but we've used a lot of contrast. We just want to cool them off in the wards for a few days to do it before they leave the hospital as part of that same hospitalization. And then of course, some patients, there are other clinical reasons for bringing them back as outpatients down the road for a second procedure to do the non-culprit vessel. So I don't have a one size fits all. It depends a lot on the specifics of the case. And I do each one of those patterns, as I'm sure all of you do as well, depending on specific circumstances.
So what I can understand from you that you still would depend on an FFR. I know, giving the pool of data that we have, and you talked about the hyperemic induction. So as compared to non-hyperemic pressure ratios, I think you still would put your bet on
yeah,
FFR.
and you know, the data really does show that these non-culprit lesions are essentially stable lesions. Sure, you notice them at the time of an acute coronary syndrome, but they don't, and patients who present with acute coronary syndrome have already shown themselves to be plaque ruptures, right? So all of the kind of, whatever it is behind the scenes that leads to plaque rupture and thrombosis. So they have higher event rates than patients who've never had ACS. But those lesions are essentially stable lesions, and so I treat them just as I do all stable lesions down the road with the FFR guided treatment.
But how do you explain the difference or the dichotomy between the angiographic driven non-culprit lesion interventions in the CL-PRIT where the difference in the complete revascularization was driven mostly by a reduction in the death or MI. Whereas in the physiology-driven, say the dynamic 3 primality or with the compare acute, it was mostly driven by the reduction in revascularization, repeat revascularization, or the need for urgent revascularization, not necessarily by death or MI.
Right, you bring up a good point, and I'd say two things about that. The first is that whenever you do stenting, like angiography guided PCI, the stent rates are always higher. So this notion that there's somehow a reduction in target vessel revascularization is simply not true, because it discounts the stents that were done on the very first day. So sometimes what those trials will do is they'll randomize patients, and then they won't count the stents that are done right on that same day. They'll just look at how many stents happened during follow-up. But if you look at the total number of stents implanted, it's always higher in the angiographic arms. The second thing I'll say is that when you look at the pooled data, we put together Dynami, and we put together Compare Acute, and also FAME2 as well. And what really gets driven for the endpoints for those vessels is spontaneous MI. And so that's the piece that can be clearly reduced by PCI, and it is probably the same thing if you look at the complete trial, right? When they looked at angiographic severity, all of the benefit was for the very severe lesions by local site analysis or by central QCA. And so I suspect that the vast majority of those lesions would have been FFR positive. And what Flower MI has shown me is that if you do FFR guided PCI, you can avoid stents in 40% of patients with no issues in terms of subsequent angina or myocardial infarctions. In other words, high FFR works the same in Flower MI as it does in all the other trials. It allows you to safely defer those lesions without doing stenting.
And what would your deferral criteria be, 0.8 or a higher level?
Yeah, so I happen to be a gray zone person. So above 0.8, I almost never stent those ones. Below 7.5, I almost always do them. And between 75 and 80, I try to be a doctor and put together all of the data and think about the best options.
Yeah, great. Dr. Hazra, your comments on the lecture by Kuntal. Any questions or your comments on this lecture?
The Compare Acute trial. Look, all trial, in any trial, there is one question and answer is also one most of the time. They Compare Acute, they have said the index procedure is the winner, less than 3 days. But there are some caveats, like all-cause death was increased by 25%. The hazard ratio is 1.25 for all-cause death, but the cardiovascular death was reduced. And you'll be surprised to know that in Compare Acute, 80% are male. And like India or any Asian countries, to have 80% male for STEMI is very, very unusual. We have almost 60-40 ratio of STEMI, and there is very selective population. And third, the syntax score was 16, and 90% of the patient had 0 syntax score after completion of index PCI, which is also very difficult to digest because the syntax score 0 after STEMI, after complete revascularization is very, very rare in Asian, Indians, and especially India. Otherwise, it's a nicely conducted trial. But unlike a complete trial, which has been followed up for 5 years, largest data on STEMI, the FFR rate was 0.8%, and angiographic completeness, not on the day 0, either on the index, median days was 23 days and 1 to 45 days, again, angiography 1. So these topsy-turvy course, the roller coaster ride for angiography, FFR, IFR will continue for some more time. Flower MI, this complete revascularization in ischemia trial, left main trial, so on and so forth. But things are getting better and better, and the gaps are coming down. Again, a nicely conducted, nice presentation by Kuntal Bhattacharya. So you have any comment on all-cause death, Dr. Kuntal?
So again, sir, the all-cause death, yes, there is a significant proportion of all-cause death is higher in case of complete revascularization group. But the data does not show that the exact, it is maybe some increased bleeding is also there in the complete revascularization group. Maybe contrast related issue, other cause, AKI, I don't know. It is not mentioned clearly.
Right. So that means you do completeness. Maybe he developed AKI later on. He may develop due to this AKI, he may die. So all-cause death is different from cardiovascular death. So he may survive the initial onslaught, but he may die due to some other causes sometime down the line. Again, it is nicely conducted, a nice presentation. Over to you.
Thank you, sir.
Over to Dr. Deb for his final words and conclusion, sir.
Thank you so much, all of you, all the participants, particularly Dr. Johnson, for his excellent conduction of the whole imaging, and followed by the physiology conclave. And we learned a lot, and I hope that all the operators would definitely have some influences based on the discussions today in their current practice. And with all these words, and thank you to all the moderators, speakers, and panelists and experts, I conclude the session for Kolkata Live, session 2, and wishing everybody a safe coming days in this COVID era. I wish everybody a healthy life.
And from the core of my heart, I'd like to thank Dr. Neil Johnson. This is my second time, and congratulations for your defined flow study, where you have included CFR in addition to FFR and this beautiful car. Definitely thanks for coming to India virtually.
Thank you so much for the opportunity. Have a